Okay, well, thank you, everybody, for attending online, on demand. We're very excited to be running this very important webinar today on prostate cancer and radiation. My name is Matthew Britland. I've been involved in cancer for 23 years in various clinical roles, and also I've been a medical director for industry, working in prostate cancer for many years. I've had a lot to do with the PCFA, and it's a privilege to be here to host. So thank you. We're here today to talk about radiation therapy and to look at different forms of radiation therapy for prostate cancer or radiotherapy. To discuss the landscape with me today and survival and provide an insight into newly diagnosed men, what to expect, we've got an absolutely fantastic panel. I'm joined by leading radiation oncologist, Dr. Vincent Pow from the Icon Cancer Centre in South Australia, PCFA specialist nurse, Kerry Santoro, and prostate cancer survivor, Peter Aubourg. We're going to dive straight in to the topic of the day, and then we're going to answer some questions that have come from men impacted by prostate cancer or possibly their carers. So turning first to you, Vincent, and thinking back over the last 5 years, what would you say have been the most exciting developments in the field of radiation oncology for prostate cancer?
Thank you, Matt, for the introduction, and thank you all for tuning in. So I'm very excited to be here and talk about what's new and exciting in the world of radiation oncology. Look, the last 5 years has really flown by. I think with significant advances in radiation oncology, it's really been driven by high quality clinical trials and rapidly evolving technology. The most notable developments and patterns I've seen in Australia, I think, would be the wider adoption of what we call hypofractionation over conventional fractionation. So that involves delivering higher doses of radiation in fewer treatments. Conventional treatment's normally done over 7 to 8 weeks, and now we're really shortening that treatment to sort of 4 to 5 weeks. And that's really been backed by large international randomized trials showing that hyperfractionated treatment is as effective and also has similar long-term low toxicity rates. And so this approach has certainly gained wider acceptance and is now really the preferred and standard option in many established guidelines for most localized prostate cancer categories. And ultimately, obviously, this leads to better convenience for the patient, less interruption to their daily life, and obviously a less cost associated with care in the healthcare system. I think following on from that vein of less treatments is really the move again further to ultra hyperfractionation, or what you might have heard as SABR or SBRT. And this is really another highly precise radiation therapy technique. And it delivers even a higher dose of radiation in even a shorter amount of treatment. So that's going now down to maybe 5 to 7 treatments. And once again, that's backed by several international randomized trials showing that that is very safe and effective. Longer term data is certainly awaited, but it is very convenient and very appealing to patients, particularly those who live rurally or remotely. So that's rapidly been embraced in clinical practice and also supported by international guidelines. So I think the reason why we can do all this and increase the radiation dose and reduce those treatments is because of advanced imaging techniques and what we call image-guided radiotherapy. So more use of things like the multi-parametric MRI and PSMA PET scans, some of this imaging modalities have really played an important part in prostate cancer management. It's showing better visualization, characterization of the tumor, and it's aiding us in better planning and target delineation. And it's just allowing us to make better treatment decisions. So an image-guided radiotherapy, basically taking an X-ray or an X-ray image immediately before or after the treatment. And this, again, aids in the precise delivery of the radiation therapy. And again, allows us to precisely target the tumor and minimize radiation to the surrounding healthy tissues. Finally, I want to say that on top of image techniques, I think it's more advanced and complex planning techniques that we're using more frequently now. So we have moved away from what we call 3D conformal therapy, which is more of a cruder technique, I guess, simpler technique where we use only a few fields of radiation, to now most centers, I would assume, would be using VMAT technology, which stands for volumetric modulated arc therapy. And that's radiation delivered in a series of continuous arcs around the patient. And that's allowing, again, to shape the dose better, spare the normal tissue and organs, and allows for better treatment plans and more efficient treatments and a better patient experience.
Wow. I mean, I think that's one of the biggest things, Vincent. There's a huge stigma, obviously, with radiation, and certainly I've seen it and you've seen it. It's getting so much more specific and so much more sensitive and so much more targeted, almost like, you know, how medicines and targeted therapies have started to evolve. And so I think that's a really important message that you know, patients, men with cancer, men with prostate cancer, don't need to be as afraid as probably the stories. I certainly know when you Google something like radiation, Dr. Google can give you such wayward information. And I'd love to actually at the end, maybe if we've got chance, get your thoughts on the PSMA that you mentioned. I think that would be important if we get to it as well. So I'd come back to that if I can, but thank you so much. Kerry, turning to you as a role as a prostate cancer specialist nurse for PCFA, can you tell us more about the challenges men go through with this experience and the support that you're able to provide to these men and their families and the carers as well?
Yeah, thanks, Maddie. So as a prostate cancer specialist nurse, I pretty much support men and their families from straight at diagnosis and beyond. And it's obviously a very confronting and potentially life-changing moment to be told that you've got prostate cancer. So a priority for me is really to ensure that men and their families understand prostate cancer as a disease, and then what treatment options may be available to them after their diagnosis. And if they don't have access to a prostate cancer, to be having these conversations with their treating physician. If they're going to go online, then certainly the Prostate Cancer Foundation of Australia website is obviously the one that I'd recommend they look at, as this has some excellent information about the different types of radiotherapy that's out there. And there's lots of good written resources available to them that they can print off or download. But also consider contacting the Prostate Cancer Foundation telenursing service, because this can be an excellent point of contact for men and their families who want to have a conversation with a prostate cancer nurse about their sort of situation, their disease. For me, in my role, it's really about making sure that my patients and their partners feel that they can rely on me to be a primary point of contact for them, and that I also provide them with unbiased, honest information about their options for treatment, so that when they come together again with their treating physician, there's a shared decision-making process that goes on. And I think the challenge these days with understanding radiotherapy is that there's been so many advances, as Vincent's just mentioned, in prostate radiation, and these are continuing to evolve. So there's lots of information that men are receiving either through social media outlets or from friends and family that have gone through a similar experience. So I think it's really important as clinicians that we can clearly explain to patients the different types of radiation that we offer at our treating centres. And then sometimes we might be recommending one treatment over another, and being able to explain that to a patient and their family as to why we would recommend that is really important as well. I think that the challenges that men face during and after radiotherapy are predominantly around bladder, bowel and sexual dysfunction. And I think as clinicians, we also have a duty of care to be carefully assessing a man's pre-treatment bladder and bowel and sexual function, because we know that if they have issues with any of those functions, then potentially radiotherapy may worsen those symptoms. For example, if a man has bladder outlet obstruction, so he has an enlarged prostate and he has poor flow, he has to strain to empty, he's getting up a lot at night, then we know that radiotherapy may exacerbate those symptoms. So if we're asking those questions and assessing that man pre-treatment, then we're able to identify any potential problems moving forward, and hopefully we can also look to treat them effectively before they go and have radiotherapy. And sometimes this can be as simple as lifestyle changes, or using a medication, or even doing a small surgical procedure to help open up the outlet and improve their flow. And certainly to help reduce toxicities to treatment, I always encourage men who are having radiotherapy to carefully follow the instructions of preparation that's given to them by the treating team. I know that certainly the centres that we refer to, men are given a very clear list of different foods and fluids that they need to avoid during treatment, foods that might cause excess flatus, and fluids that might irritate the bladder, like caffeine and alcohol. And certainly I encourage them to make sure they clearly follow the instructions that the RADONC team's giving them in preparation for their treatment each day.
Okay, that's quite amazing. It certainly seems that, well, a message I think is important for men with prostate cancer to know that they don't have to go through radiation or any therapy alone, and that we've got this team of dedicated PCFA nurses around the country to help. Just a quick question on that though. Have you seen the amount of specialist nurses generally throughout the profession change in the last 2 or 3 years? How's that role evolved from a traditional nurse to a specialist nurse?
Yeah, and I think that the Prostate Cancer Foundation have worked extremely hard and done extremely well to get, nearly, I think it's over 100 prostate cancer nurses around Australia now, and that's in both metro and regional areas, which is fantastic because it's great for men and their families to have that support. I think being a specialist nurse, it just means that you're specialising in prostate cancer. I literally live and breathe this disease every working day. And what that means, I think, is you become good at understanding patient experiences and learning from our patients and the people that we work with. And so I think that can only benefit a patient to be able to have a point of contact and someone that they can call and just have a chat about things, ask some questions. And I think prostate cancer nurses sort of sit in a fairly unbiased space where we're happy to tell men and their partners the good and the bad things that all the different types of treatments can do, and how they can affect quality of life. And so I think that's important for men and their families to have that point of contact.
Yeah, no, absolutely. I'd love to maybe at the end again get back to you on your thoughts on health literacy and how we could potentially improve that across Australia, and particularly keen maybe later to talk about how we get out to the regional, rural, remote kind of areas, which I think is important too. But I just wanted to hear from Peter first about his experience before we go into that and some questions from the audience. So Peter, thank you again for being here. Can you share a bit more about your experience with radiation and potentially what your message is to other men considering this as a form of treatment?
Okay, thanks, Matt. What I'll do is actually do a summary going from the diagnosis right through, just to give you the background, I guess. And as a bit of background, I'll start with my father. He had a prostate removed when he was about 60, and a few years later had a lump under his right nipple. The GP at that time said it was probably just a mole, and keep an eye on it. Quite some time later, it was removed with the male equivalent of a mastectomy. It was breast cancer, and this fit, healthy man died of it 4 years later at the age of 68. I was determined to learn from this, and I've had an annual checkup with a blood test with my GP since I was in my mid-50s. The main thing was to just keep medical things monitored. And I'd certainly heard the issue of having, if you've got a history, you can see when things are changing. In April last year, I had a phone consult with my GP. It was still COVID time. I had frequent peeing at night. It had gone from 1 to 2 times a night to 3 to 4 times. And I thought, Maybe it's just what happens to older men. But I thought it was worth checking. My GP thought it was probably prostate enlargement. He said my PSA had gone from 1.5 to 3.3, but it ranges up to 6 for a man of my age. But he also said, what he's interested in is changes. And it had gone from, I think, 1.2, 1.5, 1.5, 3.3, over a period of years. So it's gradually coming up. Best have an ultrasound and see a urologist. And 2 months later, with the urologist, a PSA is now up to 5.2. I had a DRE. Best have an MRI. The results showed conflicting signs of cancer in that the MRI looked bad, but the PSA still looked okay. Best have biopsies. And after that, bad news. I had prostate cancer with a Gleason score of 9. Just have a PET scan to see its extent. The urologist went through all the side effects of the various treatments, the full menu of misery. Hey, but look on the bright side. Technology has improved a lot in the last while. 20 years ago, we'd have your balls in a bucket by now. I understand surgeons are not known for their great bedside manner. By the time my wife and I walked out of his rooms, we were absolutely shell-shocked. Voluntary assisted dying was starting to look attractive. Next step, a PET scan to see if the cancer had spread outside the prostate. And a month later, I was seeing the radiation oncologist with results that showed a lymph node within the pelvis had signs of cancer. So it was decision time, or at least dance around the unpleasant options to eventually make some sort of decision. It was just 4 months since I'd had that phone call with my GP, and the roller coaster ride seemed like it had been going on for a year. So it was totally stunned mullet, and a stunned mullet is not a great decision maker. So I would interrogate the experts. The urologist thought it was probably no benefit in having surgery. He said you're going to have the effects of the side effects from the radiation treatment anyway. If you have surgery, you just cop 2 lots of side effects. Part of the recommended treatment was ADT, and this, of course, had the ring of balls in a bucket about it. And at that time, my wife and I had had a good sex life, and I was not keen on giving that up. I was also terrified that I'd suddenly changed personality. I could not imagine not being interested in sex. It just didn't compute. So eventually, I went back to the urologist, and he explained that the ADT was actually initially the main mode of treatment, and the ADT deprives the cancer cells of testosterone that they live off. So it stops the cancer. Okay, I'd go with ADT. And he also said the Gleason score of 9 and the low PSA was uncharted territory. And he said of all of his patients, I was the one he was most worried about, which was a bit of a concern. So it'd be radiation and ADT. The radiation oncologist said she wanted to throw the book at it, as she said, and recommended going on a darolutamide trial. And this is a drug that's already used in the UK for what they call castration-resistant prostate cancers. It'd be a double-blind trial, and so I'd have a 50% chance of having the drug that I actually wanted, but a 100% chance of being well monitored over a period of years. So I thought, yeah, I'll go with that. So 2 weeks after seeing the radiation oncologist, I had my first ADT injection, and my treatment was underway. And 6 months later, I started the radiation treatment. So after all that, the ADT didn't change my personality. I still find women attractive. I still have sex with the help of a blue pill, although no orgasm. I'm not fatigued, and I still go cycling a couple of times a week. In fact, I'm right at the present time on a holiday cycling trip with a group of friends. The hardest part of the radiation treatment was actually getting the bladder full at the right time and holding it on for extended periods. The treatment was actually totally painless, but fairly exhausting towards the end and for a week or so afterwards. I empty my bowels a bit more often now than I did before, and pee at night is gradually getting better. All in all, the full menu of misery did not eventuate, but the most stressful time for myself and my wife was the 4 weeks leading up to the diagnosis, the 4 months, I should say. Not knowing, it kept going from, probably nothing, you'll probably die of it, not die with it, or the other way around. But that was the hardest part. So now it's a matter of monitoring and continuing with the ADT for another 15 months. So that's my story to date.
Yeah, well, I mean, you described it as a roller coaster. I'd say that's quite a long roller coaster and full of ups and downs. And again, I'd love to get back to you in a bit, Peter, about how we potentially could do patient education differently. How it could fill some of them gaps. I like the fact you're talking about the sexual side. I think that's something, again, PCFA have been really pushing that a lot of it is that it's almost taboo, and it shouldn't be, because every man I know, it impacts in that sexual side, and I think that we need to start talking about that further, and I really congratulate you for doing that. So I'd like to get back and talk about that education side in a little while, but I'd love to also just bring Vincent back in now, because we've seen such an exponential change in the treatments, particularly in radiation oncology, in the last 5 or 10 years with theranostics and as I mentioned, PSMA earlier. But how, in your view, Vincent, what might the future of men undergoing treatment look like, maybe 5 or 10 years?
Yeah, thanks, Maddie, and thank you, Peter, for sharing your story. I think looking forward, again, it's going to be quite an exciting time and a time of rapid advancement. And again, that's down to the cutting edge technology and the clinical trials that are continuing to drive us forward. I think really where we are headed, which will ultimately lead to better care for our patients, is once again, I think we're definitely headed towards shorter treatment courses. So as said before, I think that's going to be quite standard. And there's certainly even more emerging evidence now that even we might be able to go less than 5 treatments, some as low as 1 or 2. So watch this space. Obviously, there's not enough evidence at this time, but as the data matures, I can see that that's where we're headed, and that's really going to be a benefit to patients, as opposed to, as previously said, 8 weeks now down to only a couple of treatments will be fantastic. I think imaging technology as well continues to improve. We've obviously talked about PSMA PET, but there are more novel PET tracers, there are better MRI techniques, and ultimately that's going to lead to better tumor detection, it's going to lead to better staging, and really that initial assessment is going to guide better treatment management strategies, I think. And that precise nature of the imaging is going to help us, give us confidence really in terms of radiation accuracy. And that accuracy can lead to potentially increasing, or what we call dose escalating. And we are looking at the moment of dose escalating areas of larger areas of tumor to a higher dose. And that's also showing to be improved cure rate. So I certainly think that that's going to be quite exciting. Artificial intelligence, I think that's quite a hot topic nowadays around the world. But I can certainly see that integrating into radiation oncology quite seamlessly. we're actually already using AI and machine learning algorithms to assist in our contouring and some of our image registration. But I can see it even helping us optimize and really improve our treatment plans, make things a little bit automated, and maybe even predict some of the treatment outcomes. And I think that will lead to improved efficiency. Obviously, it leads to better accuracy. But again, I think it will lead to more personalized and individualized treatment approaches. So that will be, I think, the most exciting area that I'm looking forward to, and really a boom coming to us. I think AI will link hand in hand with another technique called adaptive therapy. So as Peter had mentioned, one of the hardest parts of the treatment is actually getting their bladder and bowels correct and, prepared every day for the treatment. I can see a future that hopefully we can do away with the daily preparation. So adaptive treatment actually adapts the treatment to the day, to the change in the shape of the tumor, the target, and the natural movements in the surrounding healthy organs. So what we hope to see is having a daily plan that can adapt to the patient specifically. And so that might hopefully do away with that tricky issue, Peter. And I think adaptive therapy not only will help that patient in that regard, but again can help us with accuracy and better dose and better accurate treatment delivery. Finally, not just in the radiation space, there continue to be improved systemic options. So improved chemotherapy options, improved novel hormonal therapies, such as darolutamide, for instance, and immunotherapy as well. And I think we will see more opportunity for radiation to integrate with those systemic therapies. What has been a shift already is we are already involved in treating the prostate, even when the cancer has spread to lymph nodes or limited sites in the bones. So I think we can also see now what we call metastases-directed therapy. So when a cancer spot has spread to a bone or a lymph node, we're actually targeting those areas of cancer spread and trying to eliminate those tumors. So opening up more avenues for patients in different states of prostate cancer. So I think that's going to be very exciting. Finally, I just want to plug for proton therapy, which is now not in the too distant future. The Australian Bragg Centre for Proton Therapy and Research is being built here in Adelaide. It is a preferred option for cancers that are closer to vital organs and really mainly for paediatric patients. But it does have the potential to further reduce those to surrounding structures and tissues. But there's still going to be a lot of research that's needed to really show the true benefit, particularly in prostate cancer. And I think its role in prostate cancer management in Australia is unclear at the moment, but I certainly, if you can look at overseas, there is centres that are treating prostate cancer with proton therapy. So again, another area to watch this space. Look, overall, I think these advancements hold the potential really for more effective and precise and tailored treatments. And I think that'll lead to improved outcomes, lower side effects, and ultimately improved quality of life for our patients.
It's fantastic, isn't it? We've gone from, quite blunt stuff, blunt instruments in terms of radiation and therapies 20, 30 years ago to what we've got now has been quite incredible. I think we moved from, we tried to get precision treatment. Now we're moving even to personalized treatment, which is really taking into the patient into consideration. You mentioned proton, which is fantastic for Adelaide. It's amazing for anybody that doesn't understand this. Go and have a look at it. It's a huge, big deal for Adelaide. Could you just quickly, Vincent, explain the very principles of radiation really simply to the viewers? What happens when you switch it on and it hits the skin and it goes into the cells? What exactly happens in there?
Absolutely, Matthew. As you said, there's a lot of stigma behind radiation. And as you say, Googling it can come up with lots of the old techniques and different modalities of treatment. Essentially, radiation therapy is using ionizing radiation or X-rays, and I like to describe it to the patient as it's the same X-ray that you've had when you take a chest X-ray or a CT scan. But what we do is we turn up the energy and we target it. And that radiation is actually causing, at a cellular level, DNA breaks and killing off cancer cells while trying to minimize that damage to surrounding structures. So it's a very safe treatment, and it's a very well-tolerated treatment in general. And the traditional external beam radiation that we've been mainly talking about, importantly, is not something that you become radioactive or it gives you anything like special powers, nothing like that. But it is, the reason why it is delivered over multiple courses is normally because we give patients packets or small doses of radiation, and it builds up to what we want. And we know that it's actually more effective doing it over multiple treatments, and also better for the patient in terms of side effects. So ultimately, our goal is to have ultimate tumor control or cancer control while minimizing side effects. And that therapeutic ratio, we are always chasing to be 100%. And so you can see and hear about what I've just been talking about in terms of the advancements. We're really trying our very best to get that to be 100% to zero, ideally, and that's where we want to head in terms of delivery.
Fantastic. I mean, it is incredibly exciting. It's incredibly exciting. Kerry, I'm going to ask you a question. So, we've heard that there's probably a lot that men and the carers also, need to ask, want to ask. But what do you think some of the questions that men should be asking? Their treating staff, the multidisciplinary team, so the doctors, nurses, etc., about radiation therapy to ensure that they're getting the right information to inform their decisions, getting back to that health literacy and the personalisation where the patient is at the centre of the decision.
Yeah, so certainly the conversations that I have with my men and their partners pre-treatment, and I think are appropriate questions to ask their treating team, is around the efficacy of the treatment, and then how that sort of compares to other treatments like surgery, for example. Because a lot of the men that I counsel have the assumption that by having surgery and removing the prostate, that the cancer is gone, it's out of the body, and it will never return. And that would be lovely if that was the case, but unfortunately we know that there's a risk of recurrence even with having a radical prostatectomy. And so it's important that men and their partners understand that radiation therapy is certainly not an inferior treatment to surgery, and in fact is equally effective in treating prostate cancer really well. Similar results to surgery. So I think that's an important thing for men to ask about and to understand more clearly. And then I think it's obviously important to ask about the short and long-term potential side effects to radiotherapy, and particularly around bladder, bowel and sexual dysfunction. And then if they develop those issues during treatment, how are they managed? I think that's also really important to have an understanding of that. For some of the men that I see, they are often working for themselves. They have no sick leave because it's their own business. And so taking time off work is a real strain financially. And so I think it's important that they are also asking those types of questions around what's the commitment involved? What do I need to do? How many days do I need to front up for this treatment? Can I still work during my treatment? Because once they find out that it's actually works really well for them to continue on with their daily activities, to continue on with work, that reassures them that this treatment won't have a significant impact on their day-to-day life and what they do. So I think that's important as well. I get a lot of questions around, as Vincent said, am I am I radioactive during treatment? So clearing that up around external beam radiation, and certainly you're not, but with brachytherapy, obviously, there's radioactive seeds inserted if you're having low dose brachytherapy. And so, then understanding what precautions a man needs to take at home if he's had low dose brachytherapy. And I think that in all the clinical centres, that's really well explained to patients and their partners. And certainly Peter touched on androgen deprivation therapy as being part of radiation treatment, and I'm seeing that more and more now. Pretty much anyone that's diagnosed with intermediate unfavourable disease or above high-risk disease, those men are generally advised to consider androgen deprivation therapy, or ADT, or hormone therapy. We're not giving you a hormone, but we're giving you a medication that blocks your body's ability to make testosterone, which is the male hormone. And I think that, look, Peter sounds like he's managed really well on hormone therapy. I look after a lot of men that have this treatment as part of their radiotherapy, and it can be quite toxic in regards to side effects on their mental and their physical health. And so I think if they're being counselled around radiation therapy combined with ADT, again, they just need to clearly understand the side effects to that treatment, the impact on quality of life, why we recommend it, the impact that it has on treating the cancer well, just so that they can make an informed decision around that.
Yeah, that's a great. That's a great answer. There's so many questions. I suppose to Peter, I think you've touched on, how you came about your decision to try radiation, but from a questions perspective, is there anything you wish you'd have asked earlier, or you've not asked at all and you wanted to ask? What advice would you give to others about what questions to ask?
The thing that Kerry just spoke about, getting an idea of what ADT was.
Yeah.
Because the radiation treatment seems like, yep, you're firing these things at this and it's killing the cells and so forth. But would Sir like chemical castration with that? It sounds like a Monty Python skit, doesn't it? You go, what? Why? And having some explanation would make that a lot better, because it was just kind of, well, this is better. It's good to have this with it. And you go, yeah, really? So that would be a hugely important thing for me.
Well, I certainly know patient education is at the forefront of, I certainly know PTFA, but all the patient advocacy groups, and I know the healthcare teams, such as the one Vincent is leading, Kerry's leading, are all really focused in on, information and getting and dispelling misinformation as well, which we've talked about. But just to follow up to that, Peter, there you go.
Can I say the other thing that is, now this is with in hindsight, you're in this weird space I mentioned before, the stunned mullet. You're in a weird psychological state. And so it's you've almost got to be spoon fed this stuff, because this stress state is hard to communicate with, I think.
Yeah. Now we've got mediums, we've got podcasts, webcasts, we've got things that you can actually you can turn into patient education. So after you've received that information, you go home. That stun does go. It takes a while, but it does go, and then you revisit that education, and it sticks, and then you can make the informed decisions. Okay, so we've got through a lot, but we've got some questions from the audience that I'd actually like to get to, so we give them the time they deserve. We're going to firstly thank you to everybody who submitted the questions prior to this. We really do appreciate it. Kerry, this one's for you. First one, could you please talk about the short and the medium and long-term effects of radiation cystitis?
Yeah, so radiation cystitis is a term that can have slightly different meanings. It can be used to describe irritable bladder symptoms. And certainly if men have this during radiotherapy and after, I find that generally they'll resolve fairly quickly, usually within 3 to 6 months after their radiation treatment, and are certainly at their worst sort of during or immediately after treatment, but improve significantly once the treatment's finished. But clinically, we also use the term radiation cystitis to define visible blood in the urine or hematuria. And thankfully, this is becoming less and less common post-radiotherapy now because, as Vincent's touched on, the technology around targeted therapy is so much better. So the sort of radiation hit to the base of the bladder is not near as much as it was, say, 10, 15 years ago. However, we certainly still see in our unit men present with this chronic problem, and it can often occur years after their radiotherapy, which can also be a challenging thing for men to sort of understand why they haven't had an issue for 3-4 years and suddenly they're having ongoing visible blood in the urine. For me, it always comes back to education and making sure that they understand why it's happening. So I try to explain to them that the bladder is a muscular organ which expands and contracts several times a day, and that the stretching of that bladder wall, which has been impacted by prostate radiotherapy, can sometimes weaken over time, and then the vessels can split and they start to bleed. And this can be mild or moderate. It can be a single episode, or it can be intermittent, or it can be ongoing and significantly problematic, sort of requiring hospitalisation and bladder washouts and things. I certainly have identified over my time that men who are on blood thinners or anticoagulants seem to be obviously at a higher risk of presenting with radiation cystitis after radiotherapy. And it can be a really difficult condition for urologists to manage. And I don't think anyone's really been able to find a 100% successful treatment to radiation cystitis, unfortunately. In my clinic, if men tell me that they have seen blood in the urine after radiotherapy, we don't automatically assume that it's radiation cystitis. So we do need to do some upper tract imaging to rule out any other potential diagnoses, and we do a cystoscopy, which is when we look in the bladder to assess the lower urinary tract. And if we find that they have radiation cystitis, then the small bleeding spots might be able to be cauterized to stop the bleeding, and then the patient might have a catheter for a day or two and some washing out of the bladder, depending on how much he's bleeding. And then we just hope and keep our fingers crossed that it's a one-off incident. But unfortunately, often it's not. And so depending on who your urologist is and what they believe to be good treatments, they may do some sort of bladder installations to try and reduce the cystitis. We don't tend to do them much here in our centre anymore. We didn't find them overly effective. We certainly look at hyperbaric oxygen therapy, which again is not something that works for everyone, but certainly there's some data to support the efficacy of this treatment in reducing sort of ongoing radiation cystitis. I have a fairly low tolerance for holding off on referring. So if they have sort of 2 episodes of blood in the urine and we've diagnosed radiation cystitis, then we'll generally refer them to our leading centre that does hyperbaric oxygen therapy, which essentially is going and sitting in an oxygen chamber which releases pure oxygen in the air at high levels of pressure. The idea is that you absorb that into the mouth and through into the bloodstream. And it's meant to be sort of helping to create new vessel growth and healing of damaged vessels, which is essentially what happens in the bladder with radiation cystitis.
Okay. And is it normally patient-reported hematuria where they say, I've got my blood, or is it urinalysis, or is it a combination of both? What's the best way for a man to really know his urine and see when there's differences and report it early? Because I know those guys tend not to report things.
Yeah, you're absolutely right. So it must be part of our questioning that we're doing at these appointments with these men after radiotherapy. When I educate and counsel them prior to treatment, I warn them that this is a potential long-term risk of radiation therapy, but the risk is small. And then when I see them for their surveillance after in my clinic, it's pretty much part of my assessment. When I'm assessing their urinary function and their bowel function, the 2 questions I always ask is, have you seen any blood in the urine. And if they say no, and I say, okay, that's fine. If anything happens before I see you next, you need to give me a call and let me know. Because as I mentioned before, you can't assume that it's radiation cystitis. And I tell them that as well, that it's likely it is, but that we need to do, a thorough workup to make sure we're not actually missing anything else.
Thanks, Kerry. Thank you. Vincent, we've had some very specific questions about spacing agents and fiducial markers. Could you first explain what on earth they are, and then just explain their role in radiation therapy?
Absolutely. Yeah, there's a lot of fun terms in radiation oncology, so I'll try to explain it as best I can. So essentially, spacing agents are gel-like substances that are implanted between the prostate and the rectum in a minimally invasive procedure. The rectum, or the back passage, and the prostate are very close together and really separated by only a very small space. And certainly this can be affected by radiation when we treat the prostate. So to help create that space, we inject that gel-like substance, and it moves the rectal wall away from the prostate and protects the rectum from radiation treatment and can reduce the risk of potential side effects. It's usually it's a very safe and naturally absorbed substance, and usually goes away within a fair few months. And fiducials is a slightly different role. I think fiducials are small markers or implants that are placed within the prostate gland to improve the accuracy of radiation delivery. So our treatment staff, we are able to precisely localize those implants, and sometimes we can actually track them live when the patient is actually having treatment. And again, it plays that really crucial role in accuracy and adjusting and making sure that what we want to deliver is where we say we're delivering it. I think importantly to know that these fiducials and spacing agents are not always required, and are just additional tools in sort of the arsenal of accurate delivery of radiation therapy. So many centres and treatments might not require these agents. And it really does come down to the individual patient circumstance and their disease state. And so I always would encourage anyone who's interested or wants to know more about them to really have a chat with the urologist or the radiation oncologist, and whether or not that's an appropriate treatment for them.
Okay, I think that was so well explained. Thank you so much, Vincent. Kerry, we've had a few members who've asked about the role of surgery and radiation, and specifically in the past, they may have been told that if they've had radiation treatment for prostate cancer, they can't have surgery later, but sometimes we hear that this isn't always the case. So what's changed? Can men have surgery and then radiation? I might ask Kerry, then ask Vincent to follow up.
Yeah, sure, Maddie. So certainly since I've been nursing, which is over 25 years, a salvage radical prostatectomy has always been an operation that's performed. So essentially that's taking the prostate out after radiotherapy treatment to the prostate. It's certainly not a common operation, and that's because of its complexity. It's extremely challenging for a surgeon to do this operation, and it must be something that is a case-by-case discussion and situation as to whether a man is suitable for a salvage radical prostatectomy. The challenges around doing this operation after radiotherapy is that the previous radiation can cause changes to the pelvic and prostate tissue, which means there's higher risks to surgery. We understand that the prostate sits or abuts really the rectum, and after radiotherapy, that tissue between those planes can get quite tacky and sticky, and you need to be able to divide the prostate away from the rectal wall. So there is a much higher risk to put a hole in the rectum with a salvage radical prostatectomy. And that's not a great quality of life outcome for someone to wake up with potentially a colostomy bag as a diversion while that hole or perforation heals. Secondly, it's not great tissue to work with because the vascularity has changed to the prostate tissue. And so where the prostate's removed and they need to make the join from the urethra to the base of the bladder, it's very difficult to get that anastomosis nice and tight and healing well because the vascularity of the tissue has gone from previous radiation. So again, that joint might take longer to heal. There'll be a higher risk of bladder neck contractures and strictures in the future, and certainly their incontinence risks will be much worse with a salvage radical prostatectomy. So it's not for everyone. It's very complex, and I guess my opinion on it is it must be a case-by-case basis, a discussion for an appropriate surgical candidate, an honest conversation with the man and his partner around the risks, around quality of life after surgery, and certainly needs to be performed by a surgeon who has high experience with this type of surgery.
Thank you. Vincent, any additional thoughts on that?
Yeah, I think Kerry nailed it on the head. I think it is certainly a case-by-case scenario, but it is an option in carefully selected cases. So it's not necessarily true that it's completely off the table. I think I might just add to that, not from the surgical perspective, but also a common question would be, well, I've had radiation to the prostate, I can't have radiation ever again. I think that again is also not necessarily true. It again depends on a number of factors in a case-by-case basis, but certainly we are seeing more and more men who have potentially recurrences outside of the prostate, or in a lymph node or a bone, where certainly at that stage radiation might be a good option for that patient. And even if the patient had a local recurrence after they've had radiation, so this is a cancer confirmed in the prostate yet again, surgery, yes, is an option. We also have other options like focal therapy, which is an appropriate option. So things like high intensity focused ultrasound, cryotherapy, or even salvage brachytherapy. So there are actually many established appropriate treatments, but obviously it requires that multidisciplinary collaboration approach and that expertise from multiple sources to make sure that we're actually selecting the patients and not doing them harm, because there are also better, systemic therapies or hormonal therapies or chemotherapies that these patients can have that may not affect their quality of life as much going forward.
Thank you so much, Vincent. Okay, that's a great answer. We're nearing the end, I've noticed. It's gone so fast, but we do have another couple of questions, and I'll aim this one at Kerry. We've talked a bit about sexual function. Again, we really think we should be talking a lot about this more. Radiation therapy has potential for serious side effects, we know, on the male reproductive system. But should a man have sex, Kerry, during the weeks of radiation? Is that useful in keeping things operational?
Yeah, sure. So look, this isn't a theory of efficacy that I've heard in the past, so I'm not sure I will answer this question well, but I'll give it a go. What I would say that if men and their partners are still hoping to have children or they haven't finished their family, then men should certainly do sperm banking prior to any treatment that they have for prostate cancer. We know that radiotherapy can damage the ducts and reduce the seminal fluid as well, and this can compromise the functionality of the sperm. And certainly if a man's having brachytherapy, they'll obviously be educated around sexual function and safety to their partner and the need to wear a condom for a period of time after brachytherapy. If the question is more directed around how radiation therapy affects sexual function, the ability to get an erection, then certainly we know that there can be a decline in sexual function after radiotherapy, but it often doesn't present itself immediately. And sometimes you don't see that slow decline until sort of 12, 18 months post-treatment. So certainly any man that I counsel that's having radiotherapy, I tell them in regards to sexual function, and if they're keen on preserving their sexual function, that they need to be as active, sexually active as they can after, during, whenever their radiation treatment, just to ensure that they continue to have that good blood flow to the penile tissue. The old saying of if you don't use it, you'll lose it is absolutely true when we talk about prostate cancer treatments. And what men often don't realise is previous to their treatment, they may be getting small but regular overnight erections while they sleep, which just encourages that blood flow to the penile tissue. But after treatment, that often will diminish or fade away. And so what I tell them to do is if you don't have that happening anymore unintentionally while you sleep, what you now need to do is encourage that blood flow to the tissue as much as you can and as often as you can, whether that be with your partner or self-stimulation, or even consider using sexual aids like a vacuum pump to encourage venous blood flow, or medications to encourage arterial blood flow into the penis and stretch the tissue on a regular basis is really important. And I do strongly think that that will help preserve long-term sexual function in men who've had radiotherapy as treatment.
Great answer, thank you. So we're right on time, but I think I've got another question. But Peter, I'm going to ask you a question about your question. So you had a question earlier about ADT. Is it primary? Is radiation secondary? Do you want to just flesh that out a little bit and direct that to Vincent to answer?
Yeah, I guess it was trying to get an understanding of what was told to me. Is one more important than the other, or because initially I didn't have any idea what ADT was going to do, and it wasn't explained very well. But it was then suggested to me the primary treatment was the ADT, and the secondary was the radiation treatment. But hey,
yeah, that's Peter. So it's interesting, the words of primary and secondary. I can talk in general. I guess it's hard to say what is the primary or what is a secondary treatment. I think it's important to know that hormone therapy alone is not curative. And I think what it's more important to think about is hormonal therapy and radiation therapy. There's a clear synergy there. And its combination is certainly used more and more in many risk categories and disease states of prostate cancer. I think you mentioned in your particular scenario, your prostate cancer has spread to a lymph node. And I think hormone therapy there is a crucial component to your treatment. Particularly when a cancer has spread outside of the prostate to a lymph node or a bone or somewhere else, then hormonal therapy is a very crucial component to the treatment. But certainly the radiation therapy, particularly in localized prostate cancer, is the treatment that is the curative treatment. It's the one that's actually getting rid of the cancer cells altogether. So it's hard to say what's the primary or the secondary, and more that they work hand in hand at most times.
Okay.
Always your chicken and egg. Well, thank you so much. Thank you. I wanted to thank Vincent. I want to thank Kerry, especially Peter, because you're on a cycling holiday. So thank you for dialing in on your cycling holiday. But I really wanted to thank you all three for tonight. I really hope this has been useful. To those of you who are watching, if you've got more questions, please reach out and speak with the PCFA telenurse on 1-800-220099. They can help with all the questions about treatment, side effects, intimacy, and more. Please, if you've watched this, like, share, comment, get the word out, especially if comments very important. Thank you for the ongoing community support, without which this wouldn't be possible. A reminder again of that number, 1-800-220099, or go to the PCFA website at www.pcfa.org.au for more information. And our next podcast will be about incontinence during the National Incontinence Week in June. So please stay tuned for that. And again, thank you, Peter, Kerry and Vincent for today. And with that, we will finish this PCFA webcast. Thank you so much.